Hi everybody, I am absolutely delighted to be here today with Anas Younes, who is a medical oncologist and chief of Memorial Sloane Kettering's Lymphoma Service since 2013. He is working with 16 world-class lymphoma experts who are devoted to caring with people with all types of Hodgkin lymphoma and non-Hodgkin lymphoma as well. Now, spare your blushes, you are working on many different clinical trial research programs, really leading the way in the way that we can discover new treatment options to really improve outcomes and also the quality of life for people with lymphoma. And you're working across immunotherapies, targeted therapies, and also combination therapies as well. That's not enough. He's also served as the principal investigator on numerous clinical trials with people with different lymphomas, both at a national and also an international level as well. He's led the National Cancer Institute funded specialized programs of research excellence in lymphoma, focused really on developing novel treatment strategies for both Hodgkin's and non-Hodgkin's lymphoma, both at the MD Anderson and also Memorial Sloane Kettering. And if that's not enough, he's also leading a collaborative grant focused on the development of immunotherapy for lymphoma, and that's been funded by the Leukemia and the Lymphoma Society. Anas serves on the Scientific Advisory Board of the Lymphoma Research Foundation and is also a past member of the National Cancer Institute Lymphoma Steering Committee. I counted that you've been involved in over 300 scientific papers. That's what happens when I typed you in. And he's a massive advocate of social media, and so you can definitely follow him on all the different channels there. But today is all about follicular lymphoma. And our group now, living with follicular lymphoma, now has 2,500 people in it. And you have sent me all these questions in advance. So we're going to try and get through as many. But if you have a burning question as well, please do ask it on the live feed, and we'll try and get to all of those as well. One watch out for everyone. It's amazing that you're doing this, Anas, with us today, but he cannot give individual patient diagnosis in this format. That wouldn't be an appropriate thing to do. So please don't ask that and keep the questions short. So we're going to kick off. Thank you for being here today.
It's a pleasure. Yeah.
I really appreciate it. I'm going to get right stuck in, and the first area of questions, and there were lots of questions here, is around treatment. And lots of questions on rituximab. And the very first question is around, do you ever use rituximab alone for a first-time treatment, or do you always use it in combination with some type of chemo?
Yeah, excellent question. Yes, I do use it as single agent, mainly for patients who are old, cannot tolerate chemotherapy. They have heart disease, lung disease, and Rituxan works very well for these patients. Or for some patients who have low, what we call low tumor burden, who may not need big guns to start with, so we can start with rituximab chemotherapy. And if you start with rituximab as single agent, you can delay the need for chemotherapy by an average of 6 to 8 years.
Okay. So questions then about, why do some doctors prescribe R-CHOP over RB? Is it about cost? Is it about age, type? Why? Or all of that?
Yeah. No, I don't think it's about cost. The thing about follicular lymphoma that there are multiple options and they're all valid. So you need to tailor these options to the need of your patients. So, if your patient has heart disease, for example, I would not use R-CHOP. I would use R-Benda. If a patient cares a lot about his or her appearance because they're in public figure, they don't want to lose their hair, they don't care about wigs, you wouldn't give R-CHOP. If a patient has, let's say, worrying signs that the disease may be transforming, I would use R-CHOP at that. So you have options, and you have to tailor it according to what the patient's needs and patient's tumor characteristics.
So I think in the essence of that question is some of the challenges that there are with patients that have follicular, because there's no one answer, there's no silver bullet, is there, that sort of answers everything?
It is correct, and in a way, some patients who can confuse themselves in a way because they go and get different opinions at different sites and they get different answers, and all the answers are probably correct. It's just opinions and preferences, no science behind it, and they all could be valid. So, and it can be confusing to some patients. I can see that.
Okay. Question about, do we only have so many Rituxan bullets to use? If we're in remission and we do maintenance, does it decrease the effectiveness of a second treatment later?
It may, but again, it's an option. I think if you are going to have, let's say, 4-year mileage out of rituximab, you can use it intermittently, so you get like a shorter remissions, but multiple times. or you can use the whole thing up front and you get longer remission. At the end of the day, you get the same mileage.
Okay. So, whilst people are on watch and wait, would you recommend that they have CT scans?
I do, for multiple reasons, not just CT scans. I actually do also PET scan and surveillance, mainly because I'm concerned about early transformation that you could pick up by also PET scanning. So I do follow the size of the tumor, if it's causing any impending, let's say, damage to certain organs. But I also look at the activity by PET scan to make sure that there's no early transformation that I should worry about, and therefore I should direct my needle to do a biopsy from.
Okay, and so if someone was on watch and wait, how typically would you do those sorts of scans?
Yeah, not an easy answer. I initially gauge the growth of the tumor by doing imaging studies every 6 months, and if it's not growing too fast, I can space it out more. But frequently, at least the first year or so, I do more frequent imaging studies until I'm sure that it's not growing too fast.
Again, because there's no rules and everybody's is different, so you want to adapt it to that individual patient's
That's correct.
needs.
That's
Got
correct.
it. Back on the Rituxan, what are your feelings about maintenance Rituxan following R-CHOP?
It's an option. Not just following R-CHOP, it can be used following RCVP and other regimens. It can prolong the time for next therapy, what we call progression-free survival. So for patients who are too nervous about getting CAT scan and so forth, and they say, no, give me everything you can right now because I don't want to come back every time and worry about it, I think Rituxan maintenance is an option. You don't have to, because I said you can get the same mileage whether you get everything up front or you wait and get it later on. So it's what we call, it's a discussion. We talk to the patient about it, we inform them about the pros and cons, and at the end of the day, we both make the treatment recommendations.
Okay. And what about if somebody wants to quit their maintenance before completing the average 2 years? Is it then possible to bank the remainder and use it again?
There's no data about scientific data, but my guess it's probably yes. I mean, I wouldn't call it banking. People should not worry about I'm using all my ammunition. There are multiple options for patients and lifespan that they can use throughout their, let's say, treatment course. So I wouldn't worry too much about using all the rituximab up front because, oh my God, I'm going to run out of options. Rituximab is one option.
Okay. There were lots of questions on the on maintenance versus non-maintenance, especially coming out of Lugano and some of the findings there. So pros and cons of maintenance versus non-maintenance. Do you recommend it, and if so, for what length of time?
My default is not, and again, it's because there's no indication that it can make you live longer. It can delay the time for next treatment. It can delay the time for progression. But as of today, we don't have any evidence that it can make you live longer. So it's an option. As I said, patients can, sometimes prefer not to have their disease come back so quickly, so they delay the time for next treatment. And some patients say, well, listen, I already got 6 months of chemo. I want my freedom. I want to travel. I don't want to come back every 2 months again. So it's really preference.
Okay. Somebody asked a question about, is grade 3B follicular curable with chemo? I think I know the answer, that we don't talk about this disease as being curable.
Well, 3B, well, it's a tricky question here. So, 3B is frequently lumped with the diffuse large B-cell lymphoma. So it behaves somewhere between the indolent type and the diffuse large B-cell lymphoma, which is curable. So it depends on detail. So some of it can be cured with combination chemotherapy regimens.
Okay.
Yes.
Here's one I hadn't heard of. What are your thoughts on combating cancer with methadone, which apparently can make chemotherapy even more powerful?
Yeah. If I don't know about it, it means it's not important.
I'm crossing that one out then.
Take it out.
So if the lymphoma comes back after a relapse and it's slow growing, can you wait before chemo again, or can you leave it until you get loads of symptoms?
So good question. So the question, can we do watch and wait at the time of a first relapse? And short answer is yes. There's no indication that if you intervene early at the time of first relapse, I can make the patient live longer. So same principle. But the default for us, actually, we tend to treat patients earlier than the first time around, mainly gut feeling. In let's say, for clinical trials, if you want to treat patients with combination regimens, at diagnosis, we tend to use what we call the Gulf criteria. You have to have a certain tumor burden, multiple lymph nodes, certain size, and so forth. At first relapse, all you need is like 2 centimeter lesion that you can measure by CAT scan to qualify for second treatment. It shows you that the threshold for treating is much lower at time. But in clinical practice, outside clinical trials, Most of us drag our feet for a few months. Again, try to gauge it, is it growing fast? No. But we tend to treat before you reach the Gulf criteria second time around.
Got it. Now, when patients come and see you, how often are they worried about the side effects of chemotherapy? Do some believe that the treatment could actually be worse than the cancer itself?
I don't believe so. It's easy for me, of course, to say that. And again, patients vary in their tolerance and so forth. I mean, some patients frequently, because they stereotype chemotherapy effect from what they see in movies or relative that did not have good experience treated with different type of chemotherapy for different diseases and so forth, they tend to think that, oh my God, this is horrible. I'm going to be bedridden. I can't get out. I can't eat certain things and so forth. It's really not true. Chemo has side effects. It's chemo. Nobody wants to have chemo. But modern treatments for at least lymphomas can be given with not much of interference of lifestyle. You can still go to restaurants, you go to movies, you can go to the gym. Yes, of course, there'll be interruptions by the time you come to get your treatment. You may have like a day or so, like feeling down. But in general, you can maintain your quality of life while getting treatment.
So do you think we're wrong to think of cancers and chemo with these kind of blanket general terms that and we go to the worst place possible, as opposed to the world of follicular lymphoma, which perhaps isn't as bad as some of the different areas in the movies? Or
yeah, so again, if you have to remember one thing about follicular lymphoma, is that and this is the first thing I tell patients, is that it's irritating, it's annoying, it's usually not life-threatening. You know, the average lifespan right now is about 15, 20 years from time of diagnosis. You know, when you think about the average age of patient diagnosed with follicular lymphoma is about 60, 65. So like we're talking about 80, 85. You know. So it's different from other types of cancers. So you'll be requiring multiple treatments in your lifespan. Some of them will require chemotherapy. Some you can do something different from chemotherapy. But if you have a lymphoma, I think at one point you have to think that at least by today's standards, one would need chemotherapy at one point.
Okay. How do you counsel people who are really scared by the prospect of chemo and they're thinking about maybe not having treatment because of it? What advice would you give them?
I think the best thing is to be straightforward and honest and give your experience, because I've been here for 25 years. The patient never been there, so I can understand where the anxiety is coming from. Mm-hmm. So it's my job and my team's job, the nurses and so forth, is to communicate this with honesty and straightforward what to expect. Sometimes patients still would not buy that. They think, you're just trying to, be kind and nice and so forth. So sometimes talking to other patients who've been through this can be very helpful.
Okay. Now, there's a lot of, our group is a global group. We've literally got people from many, many different countries around the world. I actually need to count how many countries. But there is what we see in the group, that there's a huge discrepancy around the world about how people are treated. And not everybody is treated by someone as eminent as you in your field. What efforts are there to standardize the care around the world, especially as there's so many new things coming out now?
It's a good question. So there's always variations, not just for follicular lymphomas, in the treatment of different types of diseases, including cancer, around the world, based on genetics, based on socioeconomics, based on culture, and so forth. So there will all be variations. It's good to have options. That's the way I see it, as long as they're good options. So if someone wants to get treat a patient with follicular lymphoma in Australia with an option A and in London and an option B, but both fine, it's okay. People should not see this as a negative thing.
Okay. Well, I'm going to shift gears a little bit to a whole section I've called diet and exercise. So, and it's not about for you, it's about patients. So do you think...
I need that too.
Not at all. Do you think lifestyle factors can affect remission times?
I don't think it affects remission times. I think it's good for one's sanity. I think it's good to be active, to exercise, to get back to your normal life. I think if you go exercising good, you don't want to overdo things to prove to yourself that you're fine. But in general, regardless of whether you had lymphoma or not, exercise is good.
Okay. Would an alkaline diet assist the body in supporting healing with or without medical support like chemo?
Yeah, I hear all these things about alkaline and chelating things. I don't know what that is, to be honest with you. There's no evidence that any specific diet will change the course of the disease. So don't overdo it. That's what I tell patients. There are people who go out and go to this mega stores and get tons of vitamin C and so forth. There's absolutely no evidence that this will change anything.
Okay. What about sugar? Does refraining from it help us?
Yeah, there's again this like misconception that tumors like to eat sugar, and therefore if you starve yourself from eating like sweets, the tumor would be starved. It's incorrect, because we all have the same level of glucose. It's very well controlled. Even if you don't eat sugar, your sugar level in blood is same. So there's always sugar around for the tumor to eat from. So again, eating excessive sugar is not good for your health, but it's not going to help in starving your tumor from sugar.
Okay. Several questions about the immune system and whether boosting the immune system or making it stronger through diet could help. Any thoughts here? And the question there is on supplements, vitamins, anything that you can make the immune system better.
Yeah, again, it's a good concept. There's no scientific proof that any specific diet can change how the immune system will react against lymphomas. I think this is an area for research to be looked at. There's talks about vitamin D may help or not, but there's really no scientific proof. These are just observations.
So, and I want to be really clear, because there's a lot of discussion in this area in the group about this, and there's people that swear that it's made tumours reduce. And the reason that you don't say an emphatic yes is because there's no data, no research that's been done. But you think all of this is an area of interest, maybe, if there was funding to look at it.
So the way I look at this, what I tell patients, if you are on active treatment, stay away from all these kind of things.
Right.
Once you finish treatment, you can do whatever you want. You experiment on yourself, get mega things and so forth, fine. Although I don't feel that it is necessary. But if you're getting active treatment, stay away from these things, because we don't know how they interact with treatment.
Okay, so it's a really important lesson out there for people to really make sure that your doctors know if you are doing stuff.
Oh, absolutely, yes.
To know what it is.
That's right.
More questions, but they're basically in the similar areas around exercise and can you slow down progression through lifestyle choices. Okay, on to side effects and symptoms and post-treatment as a section. I think we've answered this one. Is it worth having Rituxan for 2 years even if it's making you ill? What will it do, or should I just stop it?
I don't know about what the question means by making you ill. And it's, of course, if it's causing side effects significantly, then you should not take it. So yes, I would have a low threshold for stopping it if a patient having side effects from it, although the side effect from Rituxan is really not very common.
Okay. Why are some people followed up with radiotherapy and some not? What's the reason and expectation when using radiotherapy after? Good
question. So radiation therapy is very effective against many types of lymphomas. We tend to avoid radiation therapy in younger individuals because there's concern that radiation may cause late cancers. But for relatively older patients with, let's say, early stage 1 or 2 lymphoma, including follicular lymphomas, radiation therapy is very effective. We tend to use it in these individuals because it's simple, not the chemotherapy, not much of side effects, and we don't worry much about having cancer like this 40 years later. Okay.
Lots of questions coming in off the live feed.
Okay.
Andy says hello, so hi Andy. Question around why can't you just cut out a lymphoma spot?
Good question. So lymphoma is a cancer of lymphocytes, and lymphocytes are everywhere in the blood, in the bone marrow and so forth. So surgery is not considered to be optimal for most types of lymphomas. Although for some, let's say if you have follicular lymphoma and then let's say you have one single lymph node in the neck, didn't know what it is, you go to your doctor and the surgeon say, let me take it out, and they take it out completely and turned out follicular lymphomas. We tend to do nothing. We just observe the patients. But for other types of lymphomas, including aggressive lymphomas, let's say diffuse large B-cell lymphoma, if we take it out completely, we still would give chemotherapy after that.
Okay. Somebody about all the evidence today says that it's not genetic, but there are people in the group that have family members that do have it, and somebody here wondering about whether 50% of their immediate families had cancer, wondering if environmental factors or hereditary thing can cause it.
They can, but not as common as, let's say, breast cancer, where we have a genetic marker. We can predict that these, the siblings or the daughters can have breast cancer. There are genetic clusters in families, so if someone has this history, I think they should have some genetic counseling.
Okay. Question from Bev. What's the difference in cure versus only remission with this cancer or non-Hodgkins?
So it depends how you see it. The most important thing is to live good quality of life. Whether you can do that with a lump in your neck or not, that is not causing symptoms. It's I mean, it depends how you see it. So cure is the optimal thing. So we want to cure all patients with cancer, but sometimes you can't cure it. If you can make the patient live with certain type of tumors without causing much of side effects, but have the same lifespan, I think that's a second best option.
Okay, and someone asking, is there any association with BRCA or the other mutations?
Not with lymphoma, no.
Okay. We're on side effects. Is it common to get lots of cysts and coughs, in your experience?
Lots of cysts? What do you mean by cysts?
That's the question. A cyst as a result of...
I don't know what that means. I don't know what that means.
Okay,
Yeah.
don't ask it. Another question on coughing, though. Is coughing linked to Rituximab?
To rituximab?
Yeah.
Coughing, it's not common unless you have lung toxicity from rituximab, which is rare. About 1 or 2% may have lung toxicity.
Okay. I can't even say that word. Can you say that word?
Mastocytosis, yeah.
So how often does NHL trigger that?
Not much.
Okay. Fine.
Short answer.
If you've had BNR the first time around and you relapse, can you have it again if the relapse has been significant over 3 years? So you've had a long gap.
For rituximab
Yeah.
again? Yeah, of course. You can
Fine.
repeat rituximab multiple times in the treatment course.
What is the actual definition for remission? If the swollen lymph nodes reduce in size and then start to swell again, is that an indication of a relapse or something else? So give me the definition for remission.
So remission means that we can't see the tumor by imaging studies. That's what remission. So we don't call it a cure because many or some patients in remission can have relapse disease, therefore not cured. So when someone, let's say, achieve remission, and the patient comes to me and say, am I cured? I say, I don't know, only time will tell. But from experience, follicular lymphoma, especially in advanced stage, we don't think it is curable today. It may be cured later on. But let's say for large lymphoma, which is a curable disease, even though in the remission, only time would tell for now. In the future, we will be able to predict this by using different methods, I think.
Okay, I'm going to come to the future soon.
Yeah.
If you're having B symptoms, how do you convince your consultant that you're having them when they believe you're not?
Yeah, B symptoms is a tricky thing because most
Can you tell people what B symptoms are?
Yeah, B symptoms are usually like fever, sweats, excessive sweats, and then weight loss. So the fever, we can measure it, but fever not always related to cancer, right? Sweats is very subjective. Some people sweat more than others for whatever reasons. And weight loss is, you can measure it, but none of them is specific for cancer. So B symptoms right now, it used to be, heavily weighted. Right now, we ask the patient, did you lose weight? Do you have it? And then yes or no, it doesn't influence my opinion much. So if you have B symptoms and told your patient, your physician didn't take it too much into account, it's okay.
Cool. There was a question on about PET scans, bone marrows required to declare complete remission, and you said yes to that. That's what you would use.
That's correct.
Advice for those who are in remission. What should we absolutely avoid? How much of it is affected by nutrition and stress? Stress comes up a lot, actually, as a question in the group.
Yeah, stress is not good for many things. It's not just for tumor. I mean, there's some sort of like, epidemiological studies showing that stress is not good for a specific type, like, say, breast cancer. It may work against you. There's no such data for lymphoma that I'm aware of. But in general, I think it's good to avoid stress. Some people have stressful life. I mean, it's too bad. And so, I don't know what you can do about that. Diet, I'm not aware of any specific diet that will make you live longer or make your remission last longer.
Okay. And my last one on side effects. Are fatty lumps a common side effect of lymphoma?
Fatty lumps, define fatty lumps.
That's the question. I'm just the messenger.
Yeah. No, I don't know. No, it's not. Some
Okay.
people gain weight, though, after chemotherapy. That's common. But I wouldn't call it fatty lumps.
Okay. Right, let's talk about the future.
Yeah.
How close are you, to finding a cure for follicular? And of the drugs in trials, any that you're really excited about?
Yeah. So I don't know if I can state that we're close to finding the cure. I think this has been used multiple times in the past, gave some false hopes to patients. So I can't claim that. I can tell you that the research is going on right now. It's amazing. So I wouldn't be surprised, let's put it that way, that if we start curing patients, I think the reason why we can't cure patients, not because the disease is incurable, is mainly because I think the treatment that we have is not as effective as we like it to be. So the treatment is changing. The problem with follicular lymphoma is to talk about a cure, knowing that patients now live an average 15, 20 years. The readout takes a long time before we find out. So I may have treatment that's very effective today, maybe curing patients, but I can't claim this until I follow the patients for 15 years.
Right.
That's the frustrating part. So we're all interested in finding what we call surrogate biomarkers that we can predict cure early on without need to wait for 15 years.
Okay. And we're already at a period where Rituxan's only been around 20 years.
Right.
So it could be curing people for longer, but you just haven't had a bench of patients that have really gone much longer than 20 years.
It's correct.
Right.
Rituxan alone by itself, I don't think will cure, but in a combination with other things. That's
but
correct.
as an explanation of what you're talking about here.
That's correct.
Just a thing on age, because it's very clear that the age in the group is much younger than the average age. And I'm just wondering, with all the advances in technology that we have today in medicine, whether the age is coming down because people are being diagnosed earlier than perhaps they would have been.
I don't think so. I think the fact that you have maybe earlier, like let's say younger, these are the patients that tend to be more active and proactive and seek information more than others.
Right.
And the median age did not change, let's say, over the last decade for follicular lymphoma.
Okay. So I'm going to go back again on the new treatments and approaches in development. Which ones do you think are the most promising? And someone says, if you were a gambling man, which one do you think is going to be a breakthrough for FL?
So follicular lymphoma is a complicated disease. As said, it's a chronic disease, tend to relapse multiple times. My guess, it will not require one treatment modality to cure it or to prolong patients' life. You need to probably come up with more than one treatment strategies. So both small molecules, targeted therapies, targeting specific what we call oncogenic mechanism inside the tumor cells that need to be tailored for each individual patients based on their tumor characteristics, and immune therapy, which can work in a more wider way. So I think the future will be a combination of both.
Okay. What's your view on obinutuzumab being better than Rituxan?
In the context of clinical trial, obinutuzumab-based regimens, when they compared to rituximab-based regimens, seem to be slightly more effective in terms of progression-free survival, next time to treatment and so forth. There's no indication that it will make you live longer yet, although again, there's short time follow-up. So there is some data that suggests that maybe more effective in the context of the dose and schedule that given in clinical trial. The skeptics can argue that it's mainly because we give more of obinutuzumab dosing compared to rituximab. Regardless, but if you use it in the way it's given in clinical trial, you get better mileage than compared to rituximab.
Okay, so you're excited about that one then?
I think it's a plus.
It's a plus. Okay. Phil in the UK was reading an article that you did in Nature's Review. Apparently you did research in clinical oncology. And one of the points in there were around many companies are developing similar drugs which inhibit the same target. And owing to the high number of drugs in development, the potential number of drug combinations is almost unmanageable. So how you prioritize, and what's being really done to address this whole issue?
It's a very, very good question. I think this is our biggest challenge right now. There's more than 800 drugs, which is good news for all patients. There's more than 800 drugs, either in clinical testing or preclinical testing for cancer. It's more than any other disease for humans. It's good news.
So that's great news then.
It's fantastic news. Question, how do you prioritize? Patient cannot wait until I test drug number 785 that is working for you, right? It takes longer time. Also, that's if you test single agent. When you start doing combinations, and the best example I bring up all the time, that if you have only 10 drugs, and you want to do doublets from these 10 drugs, right? A, B, A, C, and they go again. And then you do one clinical trial at a time. And the average to do a clinical trial of a doublet takes about 2 to 3 years. To test all combinations from only 10 drugs, and we're talking only 2 combinations, take you about 90 years. And patients cannot wait 90 years to find out which doublet's going to work.
Okay, so what are we going to do then?
Exactly.
Okay.
I'll tell you next episode.
No, we need to know now.
So all of us involved in what in testing different doublets in an unbiased way, because we have no financial interest in these things. Companies are interested, of course, because they have their own pipeline, and I can understand that. But we take a step backwards and test it on our own in an unbiased way, comparing different drugs from different sponsors, different combinations, and we prioritize them. And then, to me, I can find doublet A is better than doublet C, and then I seek it out. I say, I want this doublet. Thank you for offering this doublet because you have it, but I want this because I think this is better than others. That's what most of us do these days.
Okay. A question about actually, I guess, the genetics of lymphoma here. Do they develop from a single cell, and are they clonal in nature? You talked about unique sequences that are markers of clonality. So does that help us in any way?
In a way, yes and no. So in the simplest definition of cancer, that they all should start from one cell. And in lymphomas, they can start in more than one cell, have different genetic fingerprints at the same time. So not all of them should start from a founder cell, so they can branch out. This may become important when you talk about targeted therapy, when you're targeting a specific genetic defect in a tumor cell. So frequently you may have different genetic defects at different sites. Lymph node A can have a defect A and lymph node B, and you can't go out and biopsy every single lymph node. So the trick for this one is to look what we call liquid biopsy, because most of these lymph nodes, they spill out some of their DNA into the blood. So they feed all of them kind of blood. So you can detect multiple genetic alteration in the blood test, and that's what most people are now looking at. Can we use a liquid biopsy to substitute need for multiple lymph node biopsies?
And how close are we to a liquid biopsy?
It's being done in research. I think maybe one of them is probably approved for lung cancer, but in lymphoma, we're not there yet.
Okay. One of the things that you talked about is around detecting unique sequences in the serum of patients with lymphoma. So is that referring to the technique or a DNA-based technique like a PCR?
So we're going beyond PCR. PCR is the simplest one, where we used to look at a genetic translocation, which used to be considered the hallmark of lymphomas. This is now probably about 30 years old. It worked for some, but now we're going beyond this, because frequently tumor cells have multiple genetic defects that you need to probably more sophisticated tests to detect them.
Okay. I think this question might go back to the liquid one, but how easy is it going to be to develop this kind of detection technology for mass use in hematology clinics?
It's not going to be that complicated. It's really just you need to get samples from both blood and tumors, test them at the same time, make sure there's concordance, and come up with a diagnostic test. And there's a lot of research in this area. This is going to happen next in a couple of years.
Oh, that's really soon.
Yeah, right.
One from Nikki. I think she's in Australia, so she's asleep, I think, at the moment. Yeah. She had hot mabthera at age 32. Is this a treatment you'd recommend now to someone at such a young age?
She had rituximab.
Hot mabthera.
Hot mabthera. Okay, so this is radioimmunotherapy.
Okay.
There's two drugs that fall into this category, radioimmunotherapy. For both were approved for the treatment of follicular lymphomas. They're not as widely used as in the past. Again, mainly because people are afraid of late side effects of radiation, although there's really not much of a side effects in this. So one of them is pulled out of the market because of lack of usage, and the other one is still on the market, but their usage is extremely rare. So if the question is to me, would I use this drug today for patients with follicular lymphoma, the answer is no.
Okay. Lots of questions now on scans come up from what we were talking about, scans. Some people not being told not to have them. Can you overtreat with too many of them? How often is too often? Can you just give me a little bit more info on scans?
It's really tricky because, as we said, that the average lifespan is about 15. That's average. So some people live 30 years and 40 years. So you don't want to do too many scans. Mm-hmm. But even if, let's say, I tell the patient come back next year, but if you have symptoms, call me sooner. Frequently they come up with symptoms, and you can't ignore it. And because they're worried, and I understand that, they're always concerned that my tumor is coming back, so they come to you before they schedule up. So it's going to be a sort of tailored physician patient working relationship. But again, frequently, even though your intention is to delay the need for CAT scans, patients come up with symptoms that you're obliged to do some imaging.
Okay. Elena just wants to say that the lymphoma team at Sloane Kettering is truly amazing. Thank you.
Thank you, Elena.
And Lee Grant saying, I'm going to see you on Tuesday, Dr. Younes. Thank you for making this interview available. Yes to more info about scans still coming through on scans. Going to the future, I'm going to pass you that one back. What is the status on research into the CAR T-cell therapies? Would you say this is experimental and not yet ready to go mainstream? How close is it going to be to
CAR T
mainstream?
cells
Few
is
questions here.
So CAR T cells have made a tremendous, progress in treatment of lymphomas and some types of leukemias. The first CAR T cells that would be approved for lymphoma will be for diffuse large B-cell lymphoma. That will be probably approved this year. There's a lot of research going on in follicular lymphomas. I know a patient may feel differently, but there is a sense that there's no urgent unmet medical need for follicular lymphoma patients to treat them with something like this, that it has side effects. Whereas if you have a disease that can be, let's say, fatal, you're more willing to accept side effects from treatment that can help you out. For follicular lymphoma, I think you can't justify treatment with CAR T cells early on because it has side effects. Some people have neuropathy, some people have coma, go to the ICU, and so forth. But for someone with, again, relapsed diffuse large B-cell lymphomas, you can justify this and hopefully will cure some of them. I think this will come at one point to follicular lymphomas, but we need to figure out how can we manage side effects, toxicities. Can we predict this up front? Can we preemptively inhibit these side effects? And can we make it, potentially curative? So there's more research to be done in follicular lymphomas, and we are doing that. And for large lymphomas, it will become commercially available.
So that's an exciting one
Yes,
for the
very
future.
exciting. Very exciting. Yes.
Okay, but we need a bit more time for,
Yes.
it to develop. A question about, according to scientific literature, clinical trials have been carried out with cladribine, is that right, in people with follicular, but it doesn't seem to have led to it being introduced as a treatment option. Interested why the research is slow or why it's been dropped?
I wouldn't say the research is slow. Again, you have to balance safety and efficacy for patients with chronic diseases like follicular lymphomas. Patients who are expected to live many, many years. You're worried about introducing side effects unnecessarily early on. And cladribine and fludarabine, which was the earlier drug, they were used widely about 10, 15 years ago, and they were very effective. But we learned that they can also be toxic, and they can induce myelodysplastic syndrome in some patients, opportunistic infection, and so forth. So although they're effective, they're not needed, I think, right now to be used widely.
Okay. A question on immune checkpoint inhibitors. And I have to say, some of these medical technologies are not easy for me to read. I'm trying my best.
I would recommend you watch one of these Saturday Night Live episodes. I don't know if you've seen that one, where they
trying to do all the names.
Yes, benign instead of benign is exactly.
Okay, I'm not going to get the next one wrong.
So you're doing very well.
Okay.
Yeah.
So can you talk about studies with agents like pressure now, nivolumab?
Nivolumab, yes.
That one, and you can do that one.
Pembrolizumab.
Yes.
Okay, all right.
Do these show much promise in the treatment? And if so, how might they be used and how soon might we see them in general use?
So they are used widely in different types of cancers. They are approved for the treatment of Hodgkin lymphoma because either one of them can produce about 70% response rate in multiply relapsed patients. So it generated a lot of interest and excitement about the use of these immunostimulant agents. As single agents, they don't produce very high response rate in follicular lymphoma, but they are very good for combinations, and we're doing that. So we actually introduced one of these checkpoint inhibitors, not necessarily one of these two drugs, because now there's many of them are available, even in frontline regimen. So we introduced it with chemotherapy and maintenance. So rituximab maintenance can delay the time for next treatment. We're testing the possibility that introducing these activating antibodies in a maintenance setting, whether it would even go beyond rituximab. So there's a lot of research in this area.
That's great. Back on rituximab and obituzumab. They work apparently by binding to CD20, but there's another substance, CD19, which is expressed on B cells, which appears at an earlier stage of B cell development. CD19 is used as a target in some therapies, back to the CAR T cell therapy, but it doesn't seem to be used as a target for monoclonal-based therapy. Is there a reason for that?
No, it is being used.
Okay.
So there's in experimental trials, the single-agent activity of naked antibodies targeting CD19 has not been as good as CD20 targeted agents. But as you mentioned, there's different tricks for that. We can still use CD19 as a target, either through CAR T cells. Most of them target CD19. There's other targets. But there's now a lot of what we call bispecific antibodies that have two heads. One target CD19, one target CD3 on T cells, so bring T cells to the site of the disease. So there's a lot of research going on about targeting CD19, not necessarily with the naked antibodies like rituximab.
So how do those targets, these substances, actually work with patients with lymphoma? Is that what you were just talking through there, or is there something specific how it works on the lymphoma side? This question.
Yeah, this is for lymphoma
Yeah.
patients. So we have a naked antibodies like rituximab targeting CD19 in clinical trials. The indication that it may not be as effective as rituximab. You can think about maybe combining it, but it's not going to replace rituximab. Let's put it that way. It's not going to replace CD20 targeted antibodies. It may be add-on.
So, a question about personalised cancer vaccines. They've been developed and started to be used with some degrees of success. Is it possible to create these for FL?
So vaccines therapy was very hot, let's say 20, 15 years ago, because it worked for some patients with follicular lymphomas before rituximab. We learned with time that using naked antibodies like rituximab could be as effective, maybe more effective than the vaccine therapy. So this fell out of the treatment strategies for lymphomas. And I don't know if anyone is working on the old-fashioned vaccines. You can think about these immune checkpoint inhibitors that you mentioned that activate the patient's own immune system to fight cancer. You can think about it sort of like vaccine therapy, but it's not. So the goal of giving a vaccine to activate your own immune system, if you can do it by other means, it's okay, and we are doing it by other means.
Great. More questions coming through. Back on scans still. How much exposure and risk is it having a CT with contrast or a PT? Are there similar exposures or one versus the other?
Well, it depends on the machine and in the methods and the time of exposure and so forth. In general, a full body CT scan probably give you the same radiation exposure as a PET CT.
Okay. Pamela's asking, if R-CHOP's used for frontline treatment, what would be used if relapsed?
Good question. So we tend to alternate, or like sequence them differently. If you start with R-CHOP, next time we can use R-Benda. If you start with R-Bendamustine, we tend to use R-CHOP for now. Things could change in the future.
Okay. One from Phil, and Phil's always great in our group here, giving really good questions and advice. What is T-cell exhaustion? He says, apparently T-cells present with the tumour microenvironment have an exhausted phenotype. What does this mean, and how do T-cells become exhausted in lymphoma?
T-cell exhaustion refers to the one's own immune system, which is T-cells, getting tired and fatigued, unable to fight cancer anymore. And there's reason for that. The most common reason is that the cancer cells secrete or certain proteins that can make the immune system exhausted, sort of like the kryptonite in the Superman movies. You put it like this, and T-cells go, I can't fight anymore.
Right. Question on lenalidomide. Is that the next wonder drug, or does it produce a wonder drug when combined with something like rituximab?
So lenalidomide is what we call immune modulating drug that has been used as single agent and in combination with rituximab. It makes rituximab more effective. So the combination of lenalidomide and rituximab is widely used in follicular lymphomas and other types of lymphomas. I don't know about the next one. The drug has been going on for more than 10 years.
Okay. Somebody's asking what your thoughts are about, is it Laetrile? L-A-E-T-R-I-L-E. L-A-E-T.
Yeah, I have no comment on that, yeah.
Okay. How do you decide, you sort of talked on this a little bit, but come up again, how do you decide when to use stem cell replacement therapy? Is that typically after a second-line therapy, or after an R-CHOP, or after a good remission has been obtained?
Good question. So stem cell transplant used to be more widely used, autologous transplant, for patients with follicular lymphomas, because we didn't have many other options, let's say 20 years ago. So we used to use the big guns and use it. It's less widely used these days. We use it for certain indications. Someone with transformed lymphoma, let's say, we use it for them. But the common variety of follicular lymphomas who, let's say, relapse 2 or 3 times, we don't send these patients for autologous transplant. There's tendency right now to take early relapses, someone who, let's say, got R-CHOP and their disease progressed within 6 months or 1 year, to offer them something more intensive. But this is research area. So I can tell you the last time I sent one of my patients for autologous transplant with common variety follicular lymphoma, probably about 10 years ago.
Okay, it's a long time ago.
Yes.
Lots of talk in the group about fatigue as a side symptom, and wondering if you have any top tips on how you combat that.
Fatigue is, again, subjective, and it all depends on the patient's own lifestyle and how they were before starting chemotherapy. But on average, it takes about 6 months to a year for patients to recover their energy level that they had before starting treatment. So be patient, and I tell patients, don't push yourself, just be active, and it takes time. There's no special diet that will help you to, or special pills that will help you to recover your energy early on.
Okay, so it's almost take the stress out of it by knowing it's just going to take a bit of time.
It will take time for sure.
Okay. Back on the supplements point, if you take the iron, the turmeric and these type of pills, will they cause lymphoma to transform, and will it speed up bad cells as well as good cells?
I don't know about which supplement. I'm not aware of any specific supplement that will make tumor cells go nuts.
Right.
I know about many supplements that can make the chemotherapy less effective or more toxic. So that's why I tell my patients, if you want to take some supplement, do me a favor, don't take it while you're getting active therapy. If you want to do it later on, you can try.
Somebody's asking where you can get a copy of this interview. It will save as a recorded after on all the different pages, on the group page, on this page, on Anas's page, and also on Sloane Kettering's page. So it will be there for time memorial. I've got a final question, because I asked you hundreds and hundreds of questions now. It's a general question around clinical trials, why they matter, why they're important, and what would you suggest to a patient thinking about taking part in one?
It's a very good question. So 20 years ago, we used to offer patients clinical trials based really on try and error. We still do that in a way. But we used to offer the patients with lung cancer, pancreas cancer, lymphoma, colon cancer, the same drug, because we didn't know how it's going to work, and try and error based on good intention and see what happens. Worst, when we used to offer patients phase 1 trial, that's what gave clinical trials, I think, a bad name. We used to go to patients who were generous, and then usually go to end-stage patients, say, well, listen, would you help us out, test the drug on you, because we're testing how much a patient can tolerate side effects of treatment before we offer it to other patients. And would you do it for humanity? And many of patients would be kind and says, yes, I'll be happy to help, even it may not help me. Those days are almost over. We don't do this anymore. Because even if we offer patients a phase 1 trial, we expect to help you out through phase 1 trial. Because most of them are really rationally designed. And most of actually, I can tell you, every single drug approved for lymphomas or even hematologic malignancies over the last 10 decades have shown activity in a phase 1 trial. That tells you how, we expect this. So if we don't see activity in the context of phase 1 clinical trial, we dump the drug. We're not interested anymore. So phase 1 is expected to help patients. Yes, we learn more from a phase 1 because of blood testing and pharmacokinetics, but the goal is really to help patients, not just to experiment on them.
Great. So it was interesting that you said there that it still has a bit of a bad name, perhaps clinical trial, so patients might be a bit apprehensive.
Yes.
But should they be apprehensive going into a clinical trial?
It's good. I don't know about apprehensive. I think it's good to know, to learn, educate yourself about the trial, why we're doing it, what's in it for you, because that's what you need to know, that it's going to hopefully help you out. So you need to know what the odds and so forth, potential side effects and benefits, and then make a decision. And I think most of the times these days, clinical trials are expected to help patients.
Cool. So that brings us to the end. I don't know if you've got any final thoughts that you want to share with all the people that are watching live at the moment.
First of all, I'd like to thank you very much for doing this. This is really nice and kind of you to do this. It's important. The more patients are educated about their disease, the better for everyone. And I love patients who know more and ask questions. It makes my life much easier. I love patients who trust me and say, well, whatever you want. And I like that. But I also like the patient to be engaged, because it makes a big difference. Frequently, we have choices to offer, and it's important to engage the patient in these choices, because there are some preferences outside the science, and it's good for the patient to be involved in these decisions.
Okay, well, Anas, thank you so much for coming here today, for making the time to answer such a wide range of questions and to do it so eloquently.
Yes,
so
thank
really thank you, and thank you for all that you're doing to pioneer in the field as well.
Pleasure, yeah.
Thank you. Thanks for tuning in, everyone. See you soon.